probably happened to you too. In the rescue service, the emergency room, in the recovery room or the intensive care unit. You meet delirious and also comatose patients, unwind the usual frequent suspicious differential diagnoses, and this time you don't get any further. So you think outside the box of the most common top 5 and turn to the less common causes of mind shifts. A differential diagnosis in comatose or delirious patients that is often neglected, especially postoperatively, is the Central Anticholinergic Syndrome. And that's what we're talking about today.
The Central Anticholinergic Syndrome is a syndrome similar to delirium, which can be accompanied by psychomotor excitement, confusion, but also a significant reduction in vigilance with the patient being unable to contact them, as is also the case for hyper and hypoactive delirium. In addition, vegetative symptoms can occur.
A distinction is made here between central and peripheral or vegetative symptoms. The peripheral and vegetative symptoms that can occur are tachycardia, mydriasis with accommodation and visual disturbances, decreased sweat and mucus secretion with dry red skin, hyperthermia, dry mouth, swallowing and speech difficulties, urinary retention, decreased intestinal motility.
The central symptoms can be excitement as well as depression, disorientation, drowsiness to the point of coma, dizziness, ataxia, hallucinations, excitability with hyperactivity, restlessness, anxiety, cramps, short-term memory disorders, amnesia, or central hyperpyrexia.
The cause of the Central Anticholinergic Syndrome is a reduced activity of neurons, usually stimulated by acetylcholine by blocking primarily muscarinic acetylcholine receptors and/or acetylcholine depletion in the CNS. Similar to delirium, there is an imbalance between dopamine and acetylcholine in the CNS. The Central Anticholinergic Syndrome is usually triggered by medication. Above all, drugs with a direct or indirect anticholinergic effect are predestined for this. But also alcohol, plant toxins, for example angel's trumpet, henbane, deadly nightshade, various mushrooms, but also insecticides or poison gases can trigger the Central Anticholinergic Syndrome.
Drugs that can trigger the anticholinergic syndrome include anticholinergics such as atropine, scopolamine, olanzapine, phenothiazines and butyrolphenones, benzodiazepines, opioids, intravenous anesthetics, H1 and H2 antagonists, as well as inhalation anesthetics and anti-Parkinsonian drugs.
By far, the most common cause are drugs for anesthesia. Differently pronounced signs of the Central Anticholinergic Syndrome can be found in 1 to 3% of all patients with local anesthesia and in 4 to 10% with general anesthesia. The most important thing when diagnosing a Central Anticholinergic Syndrome is to think of possible differential diagnoses before making the diagnosis. Because actually the Central Anticholinergic Syndrome is more or less a diagnosis of exclusion.
Due to easy confirmation of the diagnosis ex juvantibus through the administration of physostigmine. However, one can follow this path of confirmation of the diagnosis, even if one has not first run all patients through the CT. However, with the diagnostic administration of physostigmine, the probability of a Central Anticholinergic Syndrome to be clinically and anamnestically high, as is the case. For example, in a patient with delayed awakening from the anesthesia, possibly combined with mental agitation and vegetative symptomatics. But be aware not to do this in neurosurgical patients after surgery. If there is an improvement 3 to 10 minutes after the administration of physostigmine, which is often remarkably sudden, then the diagnosis was correct. If not, you must continue to look for another cause.
Common differential diagnoses to consider are, in the case of primarily somnolent symptoms, ICH, cerebral edema, brain tumor, postictal twilight state, metabolic causes, such as disturbances in the acid-base balance, and exocosis, poisoning, endocrine disorders such as hypo or hyperglycemia, hypothyroidism and Addisonian crisis, furthermore, fever, sepsis, hypoxia, heart failure with reduced cardiac output and reduced perfusion of the brain, hypercapnia, drug overage, for example, opioids. In the case of primarily delirious symptoms, delirium, withdrawal symptoms, malignant hyperthermia, initial phase of SIRS, sepsis or infection, acute drug intoxication, drug overhang, or an acute psychosis. The treatment including that for diagnostics, is carried out as follows. Administration of physostigmine, 0.04 milligrams for each kilogram body weight in adults, which usually sums up to approximately 2 to 3 milligrams intravenous. But do not forget, due to the short half-life of physostigmine of 20 minutes to 2 hours, a follow-up injection may be necessary in rare cases. The effect occurs via an inhibition of acetylcholinesterase, which normally breaks down acetylcholine and thus leads to an increase in the acetylcholine synaptic cleft. Due to the parasympathomimetic effects, side effects can include bradycardia, AV block, bronchoconstriction, cerebral seizures, nausea and vomiting. Therefore, one must be careful in patients with coronary artery disease, bronchial asthma, and closed craniocerebral trauma, as well as myotonic muscular dystrophy.